So hi everyone, this is Nina Collins from the Woolfer, and we're here today with Dr. Tayyaba Ahmed, who is one of the practitioners at a company called Pelvic Rehabilitation Medicine. The website is pelvicrehabilitation.com. And I met Dr. Ahmed because I was having pelvic floor issues and I didn't know what they were. And it turns out that they have locations all over the country, I think in 8 different states. And here in New York, they have a location in Manhattan and in Great Neck. So I went to see her at the Great Neck location and learned so much about pelvic floor issues that I didn't know before. And I thought it would be a good conversation for us to bring to everyone here. So thank you for joining us. It's really nice to have you and to see you again. So I think the first thing we should just clear up is kind of understand, maybe you can tell us a little bit about what your practice is, because you're not a gynecologist and you're not a urologist. I had seen both those people before I came to you. You're also a DO as opposed to an MD. And I noticed on your website that a bunch of you are DOs. I actually know the distinction because I've worked in hospitals in the past, but I'm sure a lot of our listeners don't know the distinction. So maybe you could explain what the practice is, and then also what your DO means.
Okay. So we are all physiatrists, which a lot of people don't know even what a physiatrist is. We went to medical school. So some people go to either allopathic MD medical school or osteopathic medical school. It gets confusing because in Europe and some, I think even maybe Canada, osteopaths aren't actually medical physicians. So they are osteopathic physicians, but they don't go to medical school like we do. So if that distinction is probably the biggest. Here in America, we do go through the 4 years of training. We take additional classes in osteopathic manipulation, which is how we differ. So otherwise, it's exactly the same as allopathic school, except we take like 200 extra hours worth of training in this technique called osteopathic manipulation. Where I trained in New York, where I trained in New York, I tell patients if I ever see them to go, if they want a good osteopath, the best place to go is our med school, because the professors actually see patients in their office, in their clinic, and they're like, last night, this is kind of random and funny, but I was doing yoga with a friend and she's an osteopath also. And we were like, let's do some manipulation. My back feels really tight. And we were like, breathe in, breathe out. And it's very holistic. We run through the spine. It's different techniques. If people have, when your spine is out of neutral, you want to try to bring it back into neutral. So a lot of people are like, oh, is it like chiropractic? Mm-hmm. Kind of, but not, but very different, theories, and we have different techniques. So it's not just like cracking the neck. It's very, there could be very slow, minimal movements. It could be like just like squeezing a muscle until it releases. So it's similar to what's interesting about it is it's similar to like physical therapy.
Yeah.
It's longer lasting results. And that's why it's even more interesting that I'm a physiatrist, because I do believe in the rehabilitation process. The irony is that when I was in med school a while ago, a really long time ago, but physiatry was
young. How old are you?
I'm 38.
Okay.
So
okay.
It's still a while ago. So I mean, I'm getting close to joining Woolfer.
Yeah.
But for me, like, physiatry wasn't talked about. There wasn't like a 10-week class on physiatry. It was like, here's my one lecture on physiatry. It's physical medicine, rehabilitation kind of thing. And if you're interested in it, you can go into it. And now like it's growing. People are really interested in the field. It's like all the people who go to the hospital and they don't feel well and they go to there and then they get cardiac surgery or pulmonary surgery, and then they need the rehabilitation after. Mm-hmm. Same with like strokes and traumatic brain injuries, then they get the rehabilitation after. So like where you're always like, what are these places that they're going to? That's where the physiatrist is kind of taking over. In terms of pelvic, there's no real pelvic rehabilitation until now. And so women have children, and there's no, in Europe, they'll say, you have to do a couple of sessions with pelvic therapy. and evaluate the pelvic floor. And here in America, there's no such thing. You have your baby and then you go to your GYN at your 6-week follow-up, and that's the end of it.
And then
I mean, your OB, not.
yeah. Actually, a friend of mine in Paris, I was describing my problems. She's also a Woolfer, actually, and she was telling me that it's much more commonplace in France to deal with this kind of stuff, that they're just like regular pelvic rehab. It's just women who have children, that's what they do. And we don't do it here until there's a problem.
Exactly. And that's where there's like a lot of missing links for sure. And so, here, I want to say, I saw a person from France recently, and she was like, yeah, there's literally like no one to go to. And unless your one doctor happens to know about pelvic rehab or like physical therapy. And so the pelvic physical therapists have been doing this for much longer than the physiatrists, which is crazy. They 20 years ago, they started doing it on their own. And, in New York, we're really lucky. There's like a lot of pelvic therapists. There's training classes in it. A lot of young aspiring physical therapists are now going into the field of pelvic rehab. But in the physiatry world, it's even smaller. I mean, there's probably 5 of us in New York, and one in Dallas now and one in Houston. And like, not a lot of people are interested in the field because you don't go into physiatry to be like, I'm going to do rectal exams and vaginal exams. And, at first it was weird, but it makes so much more sense. And as a woman who's had 2 children, who's been on the spectrum of like, urinary symptoms, who's had other issues, like I totally can kind of see why we need this. And I think it's like a great field for people. And, I think more and more people are learning about the field and are more interested in entering it.
So interesting. I mean, I want to get down to actually the pelvic medicine part, but I could talk to you. I mean, it's very interesting to me. Like, I wonder, do you ever wish you'd become a gynecologist? Or, I mean, because pelvic floor therapy, physical therapy, which I have not done yet, even though you've told me to, and I know I need it, they literally like go in your vagina, right? I mean, when I had my session with you, let's back up and talk about the big subjects for a second, and then I'll go into that. So there are tons and tons of conditions that fall under pelvic female pain, right? There's painful bladder, there's vaginismus, there's polycystic ovarian syndrome, endometriosis, fibroids. There's all sorts of stuff that goes on, right? Now, a lot of that is treated by a gynecologist. So I'd like to understand, what you really helped me understand was the idea of this kind of sling of muscles, which I had never thought about. So I'd love it if you could kind of explain our anatomy and kind of where you're working, and also what are the main issues you see with women my age, so kind of women in the menopausal area.
All right. So first things first, men and women have pelvic floors. So everyone has one. And they're mostly the same, minus the genitalia. The pelvic floor runs between the pubic symphysis, which is the bone in the front that you feel, all the way to the bone in the back, which is the bottom of your spine, so that tailbone. And it holds everything up, like in women, the bladder, the uterus, and their descending colon, and they run through your pelvic floor, right? So when a person says, I'm having urinary symptoms, but I'm also having pain with sex, is that connected? And I show them, how connected it is. And they're like, oh, it is connected. You can have all. So women can have really overactive pelvic floor muscles where they're tight, and they can also have underactive muscles where they're loose. And both of them are weak. You don't want to be either sides of those. You want to, and I always kind of like say, a positive 10 and the negative 10, and you kind of just want to find yourself a neutral in the middle, because you don't want to be, so, because what I'm sure, and most people hear about Kegels is what they hear. Oh, you should do Kegels because those are going to save your life, and when you're in your 70s, which could be very much true in people who are having a very underactive pelvic floor and they're leaking, and they might feel pressure, which could present as a prolapse coming through, their bladder's falling or their bowel is kind of pushing through. Not fun.
No.
Then you could also, You could also have a really tight pelvic floor and your bladder is now irritated. It's causing you to feel like you have to pee when you don't have to pee, and you run to the bathroom and you go, and then nothing, a little bit comes out, and then 10 minutes later you're like, I still got to go. Or that feeling of inability to completely void. You could have urgency waking up at night, and a lot of people tell me like, oh, I wake up 4 times a night, and I'm like, that's not
That's
normal.
not
Like, this is not
normal.
normal behavior.
Right.
Yeah. And so I never was interested in gynecology, because it's a surgery. It's a surgical, it is surgery. So
Yeah.
that wasn't the lifestyle that I was looking forward to. And here in America, like, I feel like OBGYN should be like OB and GYN,
Yeah.
and not all of it, because it's so much. And a lot of times things get missed
Mhm.
because you're focusing on the OB or you're focusing on the GYN, and you're not necessarily evaluating the muscles. One of my patients, she's a GYN, and she told me like they don't learn this in residency, and she's a fellow now, and she's like, I make it a point to teach my gynecology residents to show them where the pelvic floor is and how to evaluate it, because it's not something that they're focusing on. They're mostly focusing on, where is the cervix? Let's do the pap smear.
Yeah.
Let's, check for cancer and all of, the very important
No,
things that they
no,
do.
it's really true though. And it's something we talk about in the Woolfer community a lot. I mean, a number of issues. One is like, don't believe that your doctors know everything, because they don't. They know a certain thing, right? And gynecologists, I mean, the OB/GYN thing, I completely agree with you. It's like OBs are very busy delivering babies, and women over 40, once you're past childbearing years, you really need a gynecologist. And ideally a gynecologist who specializes in older women's health, which there are very few women, gynecologists who really understand menopausal health. But it's enlightening to me that they didn't understand, that they don't really understand the pelvic floor like that. I didn't understand it all either. And what brought me to you was I started a couple years ago having those kind of what I thought were chronic UTIs, and I had never been a UTI person. And people talk about women as they get older getting more UTIs, and I was having pain, but then it turned out they weren't UTIs. So I was having urgency and frequency and discomfort. And I finally, my gynecologist, who I think is excellent, did not tell me to go see a urologist, which I really think she should have much sooner. She kept instead just treating me and, giving me, what's that pill that they give you, the black and yellow one, and they say just take one after sex every time. Like she
Like a
kept,
macrobid or
yeah, like
like,
a
yeah.
macrobid. Yeah, yeah. She was giving me macrobid. Like I wasn't having UTIs. And so I finally took the initiative myself and called a urogynecologist and saw this woman who I think is fabulous, who we've also had on the Woolfer, named Elizabeth Cavalier. And she did all these bladder things to me, like she stuck a needle up my bladder. I mean, she checked me out inside out, and she said, you're having pelvic floor dysfunction. And she was kind of like, go home and do yoga and don't worry about it. And at this point I was like, I'm actually in acute pain. Like I was having a real episode. I was miserable. And she prescribed vaginal Valium, which was a great discovery. And then I felt better. It went away. It was like an episode, but she described it as a muscle spasm. So I'm having that overactive, right? For a year,
Mhm.
nothing happened. And then it came back again. And that's when I went to you, because I posted in our community and said, like, what is going on and what do I do? And people said, you really need a pelvic floor specialist. So it was the women in the community. They were mostly pointing me to pelvic floor PT. But I came across your website and went to see you, where you explain. So, and I have a lot of girlfriends who have the leaky thing. They can't go
Yeah.
running without peeing. They're constantly peeing. So they are the ones who probably should be kegling, but people like me should probably not be kegling at all, right?
Yep. Yeah.
So are these the two main things that you treat, or is this just the most common thing you see in older women?
I mean, there's a lot of reason to why you're there, and understanding the why is what we're doing. So we're like the investigators. We're trying to figure out the why, the where, how, like, because if we, you know, if you are like, oh, I'm not having any, let's say I don't have a Peloton,
Mhm.
or I'm not spinning all the time, and I'm not bicycling all the time. But what could be the cause? So then we go into the where, like, was there previous falls on your tailbone? Are you an anxious person? Do you have pain with sex, and is it related to an unwanted sexual contact that you've had in the past? So that's how we differ a little bit. Is there a
Okay, this
hip
is
issue?
interesting. Hold on a second. Is the Peloton to blame for some of these pelvic issues? Because we love the Peloton.
No, it's not to blame, but it's not the best if you have pelvic floor dysfunction.
Okay.
So if you're like super tight and now you're sitting on that saddle that's very uncomfortable every day, like it really, in moderation, it can be really great. But if you're using it all the time, or if you, I think I had one patient who used it, literally every single day for like a year. And she came in and she was starting to present with like, I have these UTIs and they're not going away. And I go to the urgent care and they're, just the same story.
Yeah.
But she might not have, if the wrong person would not have put that together, then she could have just been having UTIs for like years and years and years.
Right.
And so figuring out, that's why going to like a physician before necessarily jumping the gun and being like, because here's the thing, some physical therapists, who, I tell people this all the time, if the physical therapist has you start doing Kegels, go run out the door, because you want to make sure that it's not just like, oh, you're here for women's health, I'm just going to go and do Kegels. Because if you do Kegels when you have a tight muscle, you're going to get tight and you're going to feel pain. And a lot of my patients will come to me and say, I did Kegels for a week and I feel worse. And I'm like, yeah, that's because that's not what you're supposed to be doing.
You have a different issue. Right. I actually wondered, because I discovered Benoit balls this summer through the community, which I thought were kind of like a novelty and kind of fun. But I wonder if they brought on this second episode, because that is definitely my problem. Okay. So tell me a little bit about the treatment for these things. Like, I've read about injections, which I'm a little afraid of. Oh, and I also wanted to say, one of the coolest things about when I saw you that I really loved is, so you physically did an exam, right? You put your hand up my vagina and you said like on the left side is where I was tight. So you could actually feel like by putting pressure. I just thought that was so interesting. Like it really made me visualize the whole thing.
Yeah, because there's these muscles and you have them on each side. So it's not just like, a lot of people are like, wait, my nerve, and it's kind of symmetric. So everything's kind of on each side, and some muscles are tighter than others. So like, I have hip issues. And so sometimes I'll feel it on my left and I'll feel maybe some clenching on my left, because when I'm having that pain, there's these obturator muscles that are not necessarily, they're part of your pelvic floor, but a little bit higher up. And when people present with hip issues, they typically have more tenderness in those areas. So like you were saying before, like you could come to me because you have, you're having these recurrent UTI type of symptoms, but like, what is the cause? Is it your hip? Is it a fall? Is it unwanted sexual contact? Is it endometriosis? Is it, because anything gynecologic can affect your pelvic floor, and anything GI can affect your pelvic floor. So I see a lot of patients with colitis who are like, well, how is I have colitis. How is this related to my pelvic floor? And I'll do these talks for the Crohn's Colitis Foundation, because so many GI doctors don't understand the relationship between the pelvic floor and colitis. Yeah. What you said before, when you're in a zone, like you're a doctor and all you do is that thing, that's all you see. Right. And so you really have to, like, we're very open about like working together as a team, because I'm not looking for cancer. Like, please do that somewhere else. I want you to do that before you come to me. I'm more like, let's figure out the problems in the pelvic floor together. Yeah. And, if once you've been ruled out by your GI and your Urogyne, like, I'm not looking for stones. That's just not what I do. Right. So I think.
Well, and you're also mentioning psychological issues, so anxiety or unwanted sexual experiences. So you see that psychological issues affect the pelvic floor as well?
100%. I actually was speaking with a sexologist earlier this morning, and we were talking about how, sex is very psychological. Mm-hmm. I mean, I think we can all agree, right. For men and women. And I see men, so, I see both sides of it. And it's very interesting because a lot of people associate pain with sex. I mean, I get Instagram messages all the time from people who say, when I think of sex, I think of pain. And
Oh,
I mean, who's gonna want to have sex if they think of pain every time they have sex? So working through those barriers, like we have a cognitive behavioral therapist in our group, that's part of it too. And if they've had, trauma, they need to get to the right avenues to address that. I think we were talking about treatment. So very simply, what I do, obviously you saw, I talk to a patient, I try to get the what, why, where is this coming from, because they want to know, where did this come from?
Right. And one of the things that you pointed out is I do have a difficult left hip that I've always had. And you said you should go get an MRI so we really understand what's going in there. And I haven't done it yet, but I'm going to. So, right, you figure out the why, and I do use a Peloton. All right. And so then what do you do?
And then we are always conservative. So obviously we want to try all the conservative options before we do anything aggressive. Now, in the COVID world, it's very different because sometimes people are not able to do one-on-one. They don't feel uncomfortable doing the one-on-one, especially because pelvic is so close to, you're very close to someone. We might try suppositories, like with muscle relaxants. And we might try Valium. Yeah, so like the vaginal Valium, might add a muscle relaxant to the Valium. We might do different creams. If there's an anxiety component, we might start a medication that will help with the pain and the anxiety. It really depends on the person and what type of treatment plan they want to take. I'm never going to force someone to take a medication orally if they don't want to. Sometimes people already come on some medications and it's hard to change their medications without permission. So I always reach out to their other doctors to make sure that we can get them on the same page. So I'm not stepping on anyone's toes, because that's the last thing I want to do as a provider. I really want to work together and make sure, if the person's like, I'm on Zoloft for anxiety, but they're also in pain, I may say, let's try to switch you from Zoloft to something that works for pain and mood, because I want you to have, improvements in both of those aspects of your life. And then going forward, for some people, we do trigger point or nerve block injections. And that is essentially to improve the space in the pelvic floor and, make your, I always say, water your pelvic floor. We're trying, over COVID, I started gardening and all of my plants had no roots, right? And so we are trying to create more space for these roots to grow and these nerves to literally not be squished, because if they're squished like this all day long, we need to get them relaxed. So we have to focus on the muscle and we also have to focus on the nerves. And so that's where it's not like one thing is going to fix someone. It's usually a combination of a little bit of the muscle and a little bit of the nerve and maybe a little bit of manipulation from the therapist. And if a patient is, in the injections, they make things move a little bit faster. Just for clarity, we don't do anything intravaginally, so we're not going inside the vagina, so that makes it less painful. We use a very teeny tiny needle, so it's like, if you know anything about needles, the bigger the number, the smaller the diameter, so it's almost like an acupuncture needle. And we're basically needling around the muscles and making things move faster.
If you don't go into the vagina, where do you put it? Where does the needle go?
So you can feel your pelvic floor muscles from the outside in. And so they're a little bit long, but they get into the pelvic floor, but we're going from externally. So outside of the vagina, you feel those bones, and then, different spots, but it's all external. So this way.
And for some people, the pain is in the rectum, right? So I imagine sometimes you use the Valium suppositories in the rectum also, it's all up for grabs, basically. It sounds like there's muscle issues, nerve issues, psychological issues, it can be anywhere in the pelvic floor. So it can be in the vagina and the rectum, and men and women have a lot of the same issues. So do men also have this over tightening or too loose issue? Interesting.
Yeah. So I had a male patient who had a prostatectomy for cancer, and his urologist had said, there's a risk of having a prolapse. So he did 300 Kegels a day for 6 months. So that's a lot of Kegels.
Yeah.
And he then presented with nerve pain in his penis, and so in the perineum, and soreness. And so, it's not anyone's fault that he's just a very good patient.
Type A, exactly. He was
type A personality. And, that's the thing, like, and we took some time. I also had a patient who was postpartum, and she was scared of, leaking, and she did a whole bunch of things and Kegels and strengthening, and she actually made herself more tight than she probably was at baseline. And so we worked on her, and depending on how quickly you are in your symptoms, the easier it is to treat. So for someone like her, we did a little bit of therapy. We started injections right away. And now she's like, great. Because I had told her, she was at her 6-week postpartum visit. And her GYN was like, why don't you check out this rehabilitation place, get yourself evaluated. But in those 6 weeks, she had already started doing like an intense exercise program of tightening herself.
right.
And I said, and based on the exam, you might have some pain with intercourse. And she was like, really? And then she's like, okay, I'm going to go home and try. And she went and she was like, you were right. And what can I do? And so we started physical therapy. We started, she was nursing, so we couldn't do suppositories. And, I work with everyone to what's safe for you, what's safe for your child. And for her, needling was going to be faster. So we needled her and we did some injections, and now she's like, I'm great. I don't need any more PT. And she knows.
When you do the injections, it tends to be like once a week for 5 weeks or something like that. Is that right?
Yeah. I mean, it depends on the person and where they're coming from. And we do make, specific exceptions for some people. We tend not to want to do too much at one time because we're using lidocaine, which numbs you. And sometimes people can get headaches. So it really depends on the person. But yeah, we do it consecutively. And, depending on the person.
Does insurance tend to cover these costs? A lot of
it really depends on the person's insurance, and we work with all major insurance carriers. So it does. It really just depends on their what the reimbursements are and stuff like that. And I tend not to get involved with any of that stuff. But yeah, many of our patients will pay nothing, and then some will pay something, and some will, it really just depends on the insurance carrier.
Got it. And pelvic floor physical therapy, which I've not done yet, involves like manual, like it's like a gynecologic exam with someone's hand inside your vagina. Is that correct?
So I've had it, and it sounds like really crazy and bizarre, but you feel really good after it because it's basically like you can't go to a massage place and say, could you massage my inner thighs and my inner, because it's like, I don't know if that person's going to want to do it. If you're with someone, and I try to pair people up with people they would feel comfortable with, people that they live nearby. Someone, if you're you're a bit older, you're not going to want to go to someone who's like 25. You're going to, so the dynamics. And if you're with someone you feel comfortable with, you feel great after. So if you're not feeling good after a therapy session, it might not be the right fit for you. It might not be maybe the person's more inexperienced, or maybe the situation, but they go in intravaginally, they evaluate you rectally. Like for me, I had constipation issues. So I learned a lot about rectal work, and just going myself has taught me about what my patients would have to endure. So I explained to them, they go in intravaginally. They'll work on some areas. They might have you, checking your strength. It seems really crazy and bizarre, but
it does sound bizarre, but I believe you, but it's great. I mean, I really need to do it, but it's interesting to talk about because it does sound totally bizarre and like weirdly intimate and kind of unpleasant, but I'm sure it's great.
I will tell you this, that I have male patients who are like, no, because they only have one hole, right? So there's only access in one way. We have two holes. So
good point.
We can get access both ways. So if you, like when someone has vaginismus, they don't want anybody's finger near them. So if they have to start off working rectally to work on those muscles from the other side, or using suppositories rectally, to get to the point where they start to feel comfortable using, the vagina as their entrance. I mean, using the dilators that we talk about. I mean, all of that. Like it takes a while to get someone fully comfortable. And it really depends on the person. Sometimes they'll go to physical therapy and they'll just do external work because you can access those muscles externally. And, a really good therapist can do a lot of good just from the outside. So it's not always like inside out, it's more like outside in. So there is definitely external work to be done first.
Wow, this is so fascinating and so important. And one other question, like I'm thinking about things like other gynecological issues like fibroids or polycystic ovarian syndrome. You don't deal with those things, right? Except in that they cause pain in the pelvic area?
Exactly. So technically, I see so many women who have never even heard the word endometriosis, and they may think that I have this cyst, and oh, I think I might have PCOS. My doctor said I might have that. I look like I could have PCOS.
Mhm.
It really depends. Like, so in my I might have a conversation about fertility, and I was talking to a woman yesterday, and she was like, "I'm in my 40s, and I want to have a baby, and I know I'm coming closer to the end, and I will have conversations about, time, sex, and understanding, because a lot of people assume if you're going to a fertility doctor, you're going just to have IVF, and that's not true. Plenty of fertility doctors will stimulate your body just so that you have sex on the right days and optimize your chance at getting pregnant. PCOS, similar, like a lot of our patients, we find that when they have pelvic floor dysfunction, they usually have a history of either endometriosis or adenomyosis or PCOS or fibroids. Sometimes they're told that they have fibroids and then they come out and it wasn't actually a fibroid. It might have been, part of adenomyosis. So it really just depends on the person, because I can't take by face value just like, oh, I have fibroids.
Yeah.
There's a good chance it's related to your pelvic floor. And, that not every patient wants to have surgery to remove those fibroids, or they don't want to have a hysterectomy, so we kind of work on their quality of life, and like, how can I make your quality of life good enough so that you don't need to have that surgery that you don't want.
Yeah, it really is a special kind of practice. I'm so glad that I met you. It seems like you guys are a interesting combination. Like a lot of doctors don't want to talk to other doctors and aren't really collaborative and aren't really thinking about all the different um,
Yeah.
different other strains,
Subspecialty.
psychological, GI.
Yeah.
Yeah,
Yeah.
so I really appreciate it. It's super helpful. Um, well, I think that's it. Is there anything I haven't covered that you want to make sure to get across?
I mean, there's so much. What's like really crazy? I always like anytime anyone asks me that, I'm always like, let's talk about PGAD really quickly,
Talk
because
about what?
this persistent genital arousal disorder.
Oh, what's
I'm
that?
always I know. And so most people hear it and they're like, oh my God, that sounds like something I want. Sign me up. It's actually really disturbing. You don't want to be aroused all the time when you're working, when you're sleeping, when you're trying to, cook and you have your children around. And I've been seeing so many people out in Long Island actually with this. And in different age groups, like 18 up until like 72.
Never
So
even
I
heard
also,
of this. This is
exactly.
persist,
Exactly.
persistent genital arousal disorder or syndrome.
Yeah.
Okay.
And so it's so taboo that nobody talks about it, because like almost all of my patients have found me through the internet from like subreddit, like
Yeah.
hidden underground like searches. And so whenever someone's like, oh, what do you want to, anyone thing you want to say? And I'm like, PGAD really quickly. Because
Oh,
it's so, I want people to feel like what they're feeling is not that they're not alone, because there is like such a high suicide rate with PGAD, and it's such a disturbing disorder, and people feel like it's hopeless and hope there's nothing that they can do about it. I mean, it's a really difficult condition.
so people who think of themselves as sex addicts, do they often have this? It's different.
No, it's not
This is just
different.
you literally walk
It's
around feeling turned on all the
like
time.
your clitoral arousal or engorgement, and having an orgasm doesn't necessarily make it go away.
Ooh.
And it's not pleasurable. It's almost disturbing.
And
It is disturbing.
do men have this or is this just women?
You know, we've seen some men with this, and it's not like when you have an erection that doesn't go away. For them, it's more they feel it when they could be flaccid.
Hmm.
It's such a like a, I feel like what we do is so different that as we start seeing more and more patients, we're learning more and more about these things, and trying to understand it ourselves, because it's so not documented. There's just
Wow.
nothing text about it. And we truly feel like it's not just something made up in their head. I mean, there is a lot of psychological to it, because they're disturbed, they get depressed, they have anxiety, and they're in pain, and it's
Yeah.
discomfort. And some present with pain, and some just don't have any pain, and they just feel this sensation.
So how do you
So
treat it?
that's part of what we're trying to figure out, and trying what to do with with our patients. Like, we're trying different options, and
Wow.
trying these injections, and we're doing a lot of research ourselves, trying to figure that out as well.
God, I'm so going to Google this. I've never heard about it. Oh, I have a question for you. Do you have an opinion about
Don't Google the stuff that you see on like Cosmo magazine, because that's the stuff that like scares people, because then they're like, oh my God, it's never gonna go away. And then they like, it becomes really depressing.
Oh no, God, I can't believe I've never heard of it. 5 years
Well,
running the
think
Woolfer.
about it. Think about it. How many women are going to be like, hey, Nina, I have this arousal thing. What do you think I should do
Well,
about it?
you'd be surprised how much we talk about in the community. So I'm totally going to post about this and be like, wait, is someone holding out on us? Like, who has this? What do you think about the Oshot?
I think that if you've previously been able to have an orgasm, you should be able to have an orgasm again. And there are different things you can do to get that orgasm. If you feel like you've never had an orgasm before, that's much harder to treat and more difficult. And I think in those scenarios, I don't think it's not it's worth a shot, literally. But in in someone who's previously had one, sometimes there are a lot of psychological barriers to it. And that is someone where, like, I don't think you necessarily need it. I mean, it's kind of like lip fillers, right? Essentially, like, it wears away. So why not just figure out the root of the problem?
Right. Got it. Okay, good. That's helpful. I interviewed a gynecologist from Texas a couple of weeks ago who does a lot of the Oshot and really likes it and does it herself. And so I've been curious about it.
Yeah.
All right. Well, this is great. I think you're fabulous. I can't wait to see you again in person. And I'm not going to let too much time go by so my problems don't get worse. And so everyone, again, who's listening, it's pelvicrehabilitation.com. And this is Dr. Tayyaba Ahmed, Ahmed. And you've just been great. And I really appreciate it. And everyone now knows a little bit more about pelvic floor health.
Yeah. You can find me on Instagram at Dr. Ty Ahmed, Doctor, and then Tay, and then Ahmed.
Oh, I'm totally going to follow you. Okay, awesome. How long have you been with this practice?
From the beginning. So it's almost 4 years.
So it's new.
Yeah, it's relatively new. I mean, that's the thing about rehabilitation. This field is, we're like the ones, like when I started doing this stuff, someone had asked me to edit a chapter on pelvic pain in a physiatry book, and I was like, I used to read these books. Now I'm the one who's like editing it. This is crazy, because it's so up and coming, and there's not a lot of people doing it now. I feel like I'm young, but I guess I'm old. So who knows?
You're still young, but you're still a leader in a new field. That's very, very cool.
Yeah.
Okay. I feel like I'm really glad that I discovered you. Like, it's because you can see that all these women kind of run around in circles, kind of gynecologists, maybe they go to the urologist. So it's really helped me help the community. So thank you very much.
I'm glad.
All right. We will see you, at some point in the future. Take care and stay safe.